All right, let's get going here. I got about like 63, 64 questions I put together. I tried not to go too crazy, but tried to, be pretty broad in covering everything we needed to. I unfortunately left out the valvular disorders like mitral stenosis and, up to aortic stenosis. I kind of just, there's a lot of things to cover, so those just kind of got left out. Also the ped stuff, kind of hard to put questions together for that. And I'm not super solid on it, so I did what I could. I think I got like five or six questions covering what I think are the big things, so hopefully that's sufficient. And for those who haven't been to one of these reviews before, as I go through the questions, feel free to unmute and answer, type in the chat. Okay, which statement made by the patient with the new prescription for metoprolol suggests a need for further teaching? So the medication will decrease heart rate and blood pressure. No, I think that's true. Beta blockers slow down the heart, decrease blood pressure. Going to be changing position slowly can drop the blood pressure, so that could be recommended. And depending on who you ask, I know it's sometimes 50 to 60. Um, you know, they might need to hold it. But yeah, it's going to be D because this is one of our cardio selective beta blockers. This is kind of geared more towards farm, but it has information. Um, kind of directed towards heart failure and other cardiac conditions we've been talking about. So for our cardioselective beta blockers, we have metoprolol and then we have atenolol. And then the non-selective ones are our propranolol and the carvedilol. And with those, the concern is if anyone has a pulmonary condition like asthma or COPD, it can cause bronchospasm. So that's where we have to consider what type of beta blocker we're giving someone. The nurse assesses the client returning from coronary angiogram in which the femoral artery approach was used. The client's baseline blood pressure was 130 over 72 and cardiac rhythm was normal sinus rhythm. Which finding should alert the nurse to a potential complication? Yep, it's going to be the change in our pulse, the tachycardia, and the rhythm change. We were in normal sinus before. Now we're tachy and having a regular rhythm. Um, when I first looked at this, I kind of wanted to pick A at the first glance reading through it because I was kind of thinking with like CABG, because when we undergo a CABG, we want to control the pressure a little more to not, um, blow the graft where we just did the surgery. So this one, you just got to make sure you read it correctly, know that we're looking at a cardiac cath instead. Which specific type of heart failure is most likely to occur at the beginning of chronic heart failure? So do both sides fail at first? It's going to be left, right, high output.
E.
Yeah, it's going to be D, B. Commonly, it's the left side first. People with pulmonary conditions like COPD, the right side can fail, but typically it's the left side. It's our big pump of the heart. That's what's putting everything out into circulation. So it has a high workload. So if things go, wrong in any sort of way, we have increased, you know, peripheral vascular resistance. We don't have enough oxygen supply to meet the demand of our big pump. It can fail, which a lot of it's on the left side. The nurse enters the room of a client diagnosed with heart failure. The client is lying in bed, gasping for air, is cool and clammy, and has buccal cyanosis. Which intervention should the nurse implement first?
D.
Sorry, did you say D as in dog?
D is in dog.
Yep, that'll be it. I'd sponge their forehead first, but this is what's right, apparently, to the book. All right, which is a common sign of right-sided heart failure? Select all that applies. So do we see a hacking cough with right-sided heart failure?
No.
No, that's more on the left side because we get the pulmonary congestion with left-sided. What about dependent edema?
Yes.
And then if we're having increased fluid, do you think our weight's going to increase as well?
Yes.
Yeah. And then what about the nausea and anorexia?
Yes.
Okay, and then oliguria, scant urine production during the day.
Yes.
That one's actually with
Left.
left-sided more so. Yeah. Um, yeah, they have oliguria during the day and nocturia at night. I believe it's because when they lay down, that fluid's more easily moved around, meaning it's perfused to the kidneys, the blood that is, and then we can produce urine. Um, but yeah, the right side of the heart that brings all the blood back from the body. So if we're not getting that blood back, it's going to stay, um, in our systemic circulation. So the fluid's going to remain there, increase in weight. We're holding on to water essentially, and then the nausea and anorexia puts pressure on the stomach and the GI tract, which can cause the nausea and anorexia. So this one's B, C, and D. Which finding does the nurse expect when assessing a patient with long-standing heart failure? Select all that apply. So weight loss, I think we can all agree that's a no. Swollen abdomen, going
Yes.
back, if they've had long-standing heart failure, say the left side has failed first, eventually the right side's going to fail with it. So we can consider, biventricular failure at this point. So, yeah, we can see those manifestations of right-sided as well. What about a third heart sound?
He's super dehydrated. Georgie, can you grab a bucket of water by the truck?
I'm not sure who that is, but unless you're answering, can you mute yourself, please? All right, so the third heart sound, that's usually the S3 gallop we hear. That's typical with heart failure as well. That can commonly be an initial sign of heart failure or worsening heart failure. And then dyspnea on exertion, especially if we have left-sided heart failure, we're not getting good cardiac output, good tissue perfusion, so we're going to get tired. The awaking was breathlessness. Does anyone remember what the technical term for that is?
Paradoxical.
See what we got in the chat. Yep, paroxysmal nocturnal dyspnea. So, yep, we could see that too. And then F, that's going to be a no. What kind of sputum do we usually see in heart failure, mainly left-sided heart failure, that is?
Pink tinged.
Right. Good. So here we got B, C, D, and E. The nurse recognizes that it's most important to assess which diagnostic tests before administering furosemide to a patient with heart failure.
A.
Can you tell me why, Anna? Can you shed some light?
Well, because furosemide tends to deplete potassium and sodium and water. So you want to make sure you're not already low on potassium.
Yep. Especially, the potassium's the big one, getting rid of the sodium. Yeah, you can be worried about that, but the low potassium, we know all the fun things that come along with that. So yeah, serum electrolytes are big with loop diuretics. The nurse is developing a discharge teaching plan for the client diagnosed with heart failure, which intervention should be included in the plan. So should they report a weight gain of more than 1 pound in a week?
No.
No, it's 1 to 2 pounds overnight or 3 to 5 in a week. What about counting their radial pulse while taking DIG?
Yes.
Yeah, I think that's reasonable. Instruct the client to remove the salt shaker from the dinner table.
It's a good idea.
Yeah, likely they're going to be on a sodium restriction, so there's already enough sodium in all the food we eat anyway, so don't add any more to it. Encouraging them to monitor urine for a change in color to dark. No, if anything, maybe keep an eye on if they're urinating, especially if if they have renal issues. And then, we want to take our diuretics early in the day and late afternoon if we have to, if it's twice a day. If we take it at night, we're going to be getting up peeing. So this one's going to be B, just B and C. The healthcare provider is prescribed an ACE inhibitor for the client diagnosed with heart failure. Which discharge instructions should the nurse include?
B.
Yep. So one of our two big side effects of ACE inhibitors are, dropping the blood pressure with a static hypotension. What is the other thing? I guess we don't really worry about it, but it's
The cough.
bothersome to the client. Yeah. So if the cough is really bothering them and they're not tolerating or they're not taking their medication, what do we move to next?
ARBs.
Yes. The nurse is assessing a client who has left-sided heart failure. Which of the following manifestations should the nurse expect to find? Yeah, it's going to be B. If we think about, left-sided heart failure, it's what pumps our blood into systemic circulation. So if that pump's failing, that blood's not, traveling well to the periphery. So those pulses will be weak. All those other signs are right-sided, fluid's not coming back to the heart. So it's accumulating elsewhere, such as in the, JVD, that's the jugular venous distension. It's accumulating like in the abdomen and the liver, spleen, and then in the rest of the periphery. Which test is used for diagnosing heart failure in a patient with a history of acute dyspnea? No, this one's
BNP.
pretty straightforward. Yeah, it's going to be our BNP. So along with that, if someone's coming in with a respiratory condition, they're having a lot of trouble breathing, a lot of chest pain, they look like garbage. There's another blood test we can use to try to differentiate whether it's a cardiac versus a pulmonary issue. So what about a D dimer? They could also use that to try to evaluate for a potential PE. It's just
That,
weekly blood.
so the D dimer is associated with the PE.
Yeah, it's a coagulatory test. Which clinical manifestation prompts the nurse to suspect pulmonary edema in a patient with heart failure? So before we get into it, what side heart failure do we see pulmonary edema with?
Left.
Yep, it's going to be the left. If you think about where the problem is in the heart, it's on the left side. Where's blood coming from? It's coming from the lungs. So if the left side's not moving it, it's going to back up in the lungs. So going forward, are we going to see increased urination? I don't think so. No. Bradycardia, no. If anything, they'll be tacky. And then The rest of them, yeah, crackles. You're getting that fluid accumulation in the lungs. They're not going to oxygenate as well, so have some difficulty breathing. And if they're not oxygenating well, they might become disorientated, confused. So it's C, D, and E. The nurse monitors for which cue in a patient with heart failure. So do you think we could see fatigue?
Yes.
Yep. Tachycardia, yeah, the heart's failing, so the sympathetic nervous system's going to kick in to try to get the blood moving. So we're going to be beating faster. Chest discomfort or pain. I mean, going along with the tachycardia, the failing heart, it's going to have a lot more demand, and we might have other issues like coronary artery disease, or even on top of that, there's a higher demand needed. So we could see ischemia from that. Sleeps on back without a pillow. If anything, they'd more than likely, have to sleep sitting up, possibly in a recliner chair with a bunch of pillows underneath them. And then we talked about the pink tinge sputum that we see with the left-sided heart failure. So this one's A, B, and C. After providing discharge instructions for a patient with heart failure, the nurse identifies that which statement by the patient indicates correct understanding of the teaching. Come on,
D?
guys, don't be scared. Yeah, it's going to be D because that's one of our, symptoms of worsening heart failure along, if we have the weight gain, the 1 to 2 overnight or 3 to 5 in a week, activity intolerance, worsening fatigue, difficulty breathing, orthopnea, all those things that we want them to watch out for when we let them go. True or false, Ashcroft bodies are associated with endocarditis.
False.
False.
What do we see them with?
Rheumatic carditis.
Good. And I don't know if this has been an issue for anybody else. Well, it was for me at first. Do these things break off?
No.
They don't. They're those nodules that develop in the endocardium. They kind of they damage the tissue, it becomes scar tissue, and then, we know with scar tissue, it doesn't maintain the functionality. So with our vegetative lesions with endocarditis, they can break off and embolize in other areas. Which assessment finding, if present in a patient with pericarditis, would prompt the nurse to suspect cardiac tamponade? So with cardiac tamponade, the heart's being restricted, right? So we're going to have issues with cardiac output. So do we think we might compensate with tachycardia, faster pumping? That one will be a yes. AFib,
No.
no, we wouldn't see that. Pulsus paradoxus,
Yes.
yeah. And what is that?
That's where there's there's a difference in your systolic blood pressure. I think was it by more than 10 on inspiration versus expiration?
Yep. So there's also the pulsus alternans, which I was getting that mixed up for a bit, and that's when like your pulses kind of change in strength. It might be bounding and then it might be thready. They kind of bounce back and forth. But the pulsus paradoxus talks about it pertains to blood pressure that drop by 10 or more upon inspiration. And then JVD.
Yes.
Yeah, if the heart's being constricted, it's not going to fill as well, so can back up systemically into the jugular veins. And then the heart's being constricted, so we're going to have decreased cardiac output. So this one will be A, C, D, E. True or false, vegetative lesions associated with infective endocarditis are unresponsive to anticoagulants.
True.
True.
Yep. So it's just kind of weird because I think it's bacteria that gets surrounded by like clotting products like fibrin, if I'm not mistaken, but there's no way to, I don't even know if thrombolytics, I don't think they have any effect on it, but they don't work. Which position would the patient with pericarditis who reports severe substernal chest pain be placed in?
D.
Yeah, they tend to feel better sitting up. The pain tends to be worse on inspiration too. Which action would the nurse take when assessing a patient diagnosed with infective endocarditis who has petechiae around the clavicles and splinter hemorrhages of the nail beds?
A.
Yeah, those are typical findings with infective endocarditis. So not really, no cause for concern. I want to put this in here just so we see that, so we, see those signs that go with certain conditions, because we've, talked about a million of them in the past 4 weeks. Hold on. Which question by the nurse is a priority for a patient who presents to the emergency department with an enlarged heart and a new murmur, along with the following vital signs: 108 over 55, heart rate of 118, saturation of 94% on room air, and a temperature of 103.4.
B.
And what leads you to B? I mean, what's the hint in the question that makes you want to say B?
Because it sounds like it's infective endocarditis, which it's usually started with a strep infection.
Right. And also, yeah, we see the signs of infection, the high fever, but also with infective endocarditis, typically it presents with a new or a change in existing murmur. So that's also, a flag as to, what it could be. Okay, which is a possible cause of infective endocarditis? Keyword is infection.
C, D, and E.
Yep. Right, those are all portals of entry for infectious organisms, so. Which cardiac condition is antimicrobial therapy likely to be used for? So cardiomyopathy?
No.
Nah. Rheumatic carditis?
Yes.
Yeah, it's caused by strep. So, initially, yeah, they'd be on antibiotics. Heart failure? No, that's not an infective condition. And Addie and Amy both say D. I agree with that, and it's an infection. And then valvular heart disease.
Yes.
Yeah, anyone who has issues with their valves is at higher risk for infection. So if they have to undergo like an invasive dental procedure, that's where we see like the prophylactic antibiotics used. So this one's B, D, and E. Okay, and what condition do we typically hear a pericardial friction rub? Yep. And so if we want to listen for it, I guess where anatomically do we listen for it?
Left sternal border.
Yep, left lower sternal border. The client is diagnosed with pericarditis. Which are the most common signs and symptoms the nurse would expect to find when assessing the client?
D.
Yep, it'll be D. We talked about, the petechiae and splinter hemorrhages are with infective endocarditis. I guess B, it's for myocarditis, but I mean, I guess any sort of infection, it's potential for that. If you have the flu, you can be tired and have joint pain. Pulsus paradoxus, we see that more so with tamponade. And I imagine the increased pain with inspiration maybe is like your lungs are inflating and it's putting more pressure on the heart and the irritated pericardium. So I mean that makes sense in my mind. So that's a big sign of pericarditis, Jesus. The client diagnosed with pericarditis is experiencing cardiac tamponade. Which collaborative intervention should the nurse anticipate for this client?
A.
Yes, so yeah, cardiac tamponade's an emergency, right? So we don't want to mess around and wait. Same thing, if someone has a STEMI, they get a trip to the cath lab. If someone's got tamponade, they need to get tapped and get that fluid drained immediately. The client is diagnosed with rheumatic fever and is prescribed penicillin. Which statement indicates the client needs further teaching prior to discharge?
C.
Yep. Do you know why? Can you tell me why?
Because medication doesn't guarantee the resolve.
That's fair. I'll take it. People people who have rheumatic carditis, they're at an increased risk for infective endocarditis down the line. I don't know if
For
it's because of its effect on the valves or because a lot of people develop rheumatic carditis due to like an unordinary immune response to a streptococcal infection. Not certainly positive, but people with rheumatic fever, they're at an increased risk for developing infective endocarditis down the line. Okay, the client has just had a pericardiocentesis. Which intervention should the nurse implement? So we just treated someone for a medical emergency. They just had a needle put into their chest cavity to drain fluid around their heart. Do we think monitoring vital signs every 15 minutes for the first hour is warranted?
Yes.
Yes.
I think so. And then assessing the client's heart and lung sounds.
Yes.
I think that's a gimme. Record the amount of fluid removed as output.
Ooh, I don't know.
Well, I
Technically,
mean,
yes.
it's come out of the body, so yeah, we're gonna record it as output. And then evaluating their cardiac rhythm.
Yes.
Yeah. And then keeping them in the supine position, no, because actually that puts more stress on the heart. Which I didn't get a solid rationale for that. I don't know if it's laying down allows more fluid return into the heart, which maybe puts more stress on it. I'm not sure, but you'd want them like semi-foulers. So this one's everything but E.
I have a question.
Yeah.
Is pericardiocentesis, is that like a surgical, or is that done in like the room because it's an emergency?
It can be
Um,
done at bedside, and it's not considered a surgical procedure or an operative procedure. It's invasive, and they do it as a sterile procedure, but it can be done at bedside.
Yeah, I don't know if ideally in a perfect world, like if someone's, I guess, stable enough, if they take them elsewhere, if they typically do it at bedside. Because I mean, I don't think you really require you don't require need a surgical suite to perform it, but I don't know if that's more ideal or not.
No, they can do
Yeah,
it the
I
same
was
way.
just asking because for C, I don't think I would have chosen that one right off the bat because I would have thought that that wouldn't have been something that I would have like been a part of to know as output. I feel like that would have been someone else recording it. That's the only reason why I asked.
Yeah, I mean, I don't know if it's a matter of, I mean, regardless if you want to say it's output or not, you want to record how much fluid came out. But I get what you're saying. Like if you're there or not, I guess this is under the presumption that you would be there because if you weren't, you can't do something that someone else is doing.
Right. Thank you.
Yeah. The client with infective endocarditis is admitted to the medical department. Which provider order should be implemented first?
B.
Yep, it's an infection, so we want to get those blood cultures and get antibiotics going immediately. Which I mean, it was a big confusion for me. I think second year or something. I was confused between like if you could start antibiotics before you get the culture, like in the emergency room, but I guess like after you get the blood cultures after they're drawn, they can start on a broad spectrum until the culture comes back because it can take up to 48 hours. But you want to get those cultures as soon as possible because you might use a broad spectrum, but depending on what organism it is, you might end up needing a narrow spectrum. So time is money in that sense. Infective endocarditis can be really dangerous and lethal. So you want to get those cultures so you get that, information back of what the organism is. And then these other things, they would be done, especially, encouraging rest, and wanting them to chill until things start to resolve so they're not putting too much stress on their heart. Which of the following is the most common etiology of hypertrophic cardiomyopathy?
C.
Do we all agree? Does anyone else want to disagree or argue? No, it is C. That's the only cause of hypertrophic cardiomyopathy. It's inherited. Which of the following are current common signs and symptoms of dilated cardiomyopathy? Select all that apply. So do you think we could see dyspnea on exertion?
Yes.
Fight you, Addie. Fatigue.
Yes.
Yeah, I think so. What about angina, chest pain? That one's a no, actually. It's not I'm sure it can happen, but it's not a common sign. And then sudden cardiac death. No, we see that more with hypertrophic. Sometimes that's people just die. They didn't ever even know they had it. That's the first thing that happens. They go into a lethal rhythm and that's a wrap. And then syncope, that's a no.
Yes.
It's also with hypertrophic, and the mitral valve murmur is as well. So, especially with the obstructed hypertrophic cardiomyopathy, the outflow through the aortic valve is obstructed. And then you have hypertrophy of the left ventricle itself. So that creates, especially with any sort of activity, there's no compensation in cardiac output. The heart can't put out enough. So the perfusion drops and people can pass out. And again, with the angina, the heart needing to work so hard to push blood out, you can develop that ischemia just from demand. And then I don't really know, with the sudden cardiac death, happens a lot in athletes. They're just more prone to developing, lethal ventricular dysrhythmias. And then the mitral valve murmur is just common with it. So this one's just A and B for dilated cardiomyopathy. Which of the following drugs are contraindicated in obstructive hypertrophic cardiomyopathy? I'll give you a hint. It's 3 Ds, which might not be very helpful, but maybe someone will get it. Yep, so C and D for sure. Cardiac glycosides, those are, that's like our digoxin, and E. So it's our digoxins, our diuretics, and our dilators. And I tried to look into this to figure out why it's contraindicated. All I could find that wasn't crazy in depth, that would take, a lot of time to figure out, was it can worsen the obstruction. I don't know if anyone has any sort of intuition that makes it make sense to them. It doesn't to me, but I just remember the 3 Ds are contraindicated in obstructive hypertrophic cardiomyopathy. Which medication is indicated for a patient diagnosed with restrictive cardiomyopathy to block inappropriate sympathetic stimulation and tachycardia? So this is less really knowing what you give for restrictive cardiomyopathy and just understanding what the med is. I figured, I can't do a review for pharm. I'll try to include a little something. But yeah, it's metoprolol. It's our beta blockers. It blocks the, beta sympathetic stimulation. Which statement made by a patient who had heart transplant surgery indicates a need for further teaching?
C.
See,
Yep. They have to take them always for the rest of their lives. With transplants, what's always our big concerns? Doesn't change anywhere we go.
Rejection.
infection.
Infection and rejection. Yep. So I guess also specifically for people with a heart transplant, what's very different about their new heart and how it can respond?
It doesn't have pain receptors.
Yep. So they might not experience chest pain. It's denervated. So baroreceptor stimulation doesn't work within the aortic arch. So, they're more prone to drops in blood pressure, orthostatic hypotension. Which nursing intervention is appropriate for a patient who is prescribed nitroglycerin? So checking the patient's drug history for sildenafil. What the hell is that?
Erectile dysfunction medication.
Thank you. So all the meds that end with a fill or just fill, as far as I know, are all the ED meds. So those and nitroglycerin are a big no-no unless you want to tank your patient's blood pressure. So that's something we want to look into. Do they need to take it with food?
No.
No, it's sublingual, so it's not even really going to absorb through the GI tract. It's going through their mucous membranes under their tongue. And then monitoring their blood pressure.
Yes.
Yeah. And asking the patient to lie with the head of the bed lowered. Yeah, that might help mitigate, any dizziness or syncope, help, maintain perfusion to the brain. So that's acceptable. And then E is a no. That's more so negative side effect we can see with beta blockers. So this one's everything. Well, A, C, and D is this one. The client with coronary artery disease asked the nurse, "Why do I get chest pain?" Which response is most appropriate?
A.
Yeah, it'll be A. Um, I think B is false because, ischemia to the myocardium isn't really a result of, low oxygen in the blood. The blood's just not getting to the myocardium. And then C is, heart failure. D could occur with a pulmonary condition, but A is simple and straight to the point. It's an issue between supply and demand. The client is scheduled for a right femoral cardiac cath. Which nursing intervention should be implemented after the seizure? The procedure.
B.
Yeah, especially with the right femoral, or I guess they're all distal. They can use the radial too, but yeah, we just accessed an artery and there's potential for occlusion. So, want to check their cap refill, movement, sensation, temperature, all those good things. We don't want to move their leg around. They're going to need to keep it straight, probably get like a soft immobilizer cast. And I guess, I don't know, semi-Fowlers would be, well, no, I actually think they position them supine to, because if you think about it in the femoral artery, if you're sitting up, you might be with your abdomen putting more pressure near the site. So they prefer them supine. And then gag reflex is not really important in this case. A nurse is caring for a client who was 8 hours post-op following a cabbage. Which of the following findings should the nurse report?
B.
B.
Yeah. So yeah, I kind of talked about it earlier in the review. We just anastomosed or grafted, blood vessels. We want to keep the pressure low so, we don't rupture the sutures or cause any bleeding. I don't know. I tried to look for it earlier, but I couldn't find it. Does anyone know if there's a cutoff, like for the blood pressure, like how high it can be? Because I don't know. I don't think it's that important to know. It's just a curiosity thing, I guess. A client is scheduled for coronary angiography, to the cardiac cath. Which laboratory findings should the nurse report?
C.
B.
So, I could see why you might want to say B, but we don't know if it's a female or a male. If it was a male,
Right.
the reference range would be low, but we don't have a
Females 12 to 16.
sex. So, but yeah, with a cardiac cath, we're gonna be using contrast dye. So creatinine's elevated, indicating an impairment in renal function. So that would want to be addressed. I think we've covered it quite enough. Assess the allergies to iodine or contrast. Look at their renal function. Are they taking like metformin? standard things before anything with contrast dye. Which fact about unstable angina is correct?
B.
It can occur either or. Stable angina, I think typically at most it lasts for, I don't know if I'm getting 5 or 15 minutes. I think it's 15, but unstable is 30 minutes or longer. It's unrelieved by rest or nitro. Stable angina occurs in a pattern that's familiar to the person, and an MI evolves over many hours. So I don't have a question in here, but I'm just going to ask someone, they have a history of stable angina, they have nitro. What's the guidelines for taking nitro, and when do you go to the hospital?
Take 1 tab every 5 minutes. If pain's not relieved after the first one, call for emergency assistance before taking the second one.
Yep. And they might be recommended to take something else while they're en route to the hospital.
Aspirin,
Yeah. How much aspirin?
4 tabs of 81 milligram.
Yeah, which is 324. My
Yes.
math is even close. Along with persistent crushing chest pain, which signs and symptoms would make the nurse suspect that the client is experiencing an MI?
B.
B.
Right, those are associated symptoms. I guess what are a couple of other of our associated symptoms we might see?
Nausea, vomiting.
Yeah, I think those are really the big ones. The client is 1 day post-op after a CABG. The client complains of chest pain. Which intervention should the nurse implement first?
A.
Yeah, it's going to be B. You want to assess them first, look at that chest dressing, see if, there's any bleeding, check their vital signs, see if, their tachycardic, blood pressure's dropping, things like that. I kind of wanted to check the tele, but you always got to check your patient first. You can't assess the monitor. But I mean, all these things are likely in the equal, maybe not encouraging to turn them side to side, but all these other things would be in the equation, but you want to look at them first. Prompt pain management for MI is essential for which reason?
B.
Yep, it's going to be B. Also, it increases preload and afterload, so that creates less stress on the heart. Nice, Ari. Good choice.
I don't want to be bothered.
Yeah, I don't think any of us do. Just dope your patient up so they're out. When planning care for a patient in the emergency department, the nurse understands that which intervention is needed in the acute phase of MI. So, I mean, kind of just talked about it. Do we think morphine's they're gonna get some of that good shit?
Yes.
Yeah. O2,
Yes.
oxygen, which I guess it's only if they're if they're short of air or they're desaturating or hypoxic. I guess it can it was in the book, if you give oxygen to someone who is adequately saturating it, they did a study that shows it increases risk for mortality. So, but I think Jen said, but depending on the provider, they might have you put them on oxygen or not. All right, moving on. Nitro.
Yes.
Yeah. So those are big ones. It's that mnemonic MONA. So you got morphine, oxygen, nitro, and aspirin, or an antiplatelet. And the acetaminophen, they can give that, as one of the side effects of nitro, which is a headache. Which atypical symptom may be present in a female experiencing an MI? So sharp inspiratory chest pain. No, that's more with pericarditis. Dyspnea. Yeah. Dizziness, yes, and extreme fatigue. Those are the atypical symptoms that women may experience. Where men typically have the more classic symptoms of the crushing chest pain that, radiates to the jaw, shoulders, down the arm. A patient has just returned from the surgical suite after CABG. For which finding would the nurse contact the surgeon?
C.
Yeah, what's our magic number for chest tube?
150.
Yep, 150 or less.
Although we just found out in clinical on Thursday that apparently at Olean General, their cutoff is 200.
No, figures. Now we're also concerned if there's none, right? What are we gonna
Yes.
think if there is nothing?
Cardiac tamponade.
Yeah. Which action would the nurse perform first on a patient who comes to the ED with chest discomfort?
B.
Yeah, we want to learn more about the pain. You know, describe the pain. Is it a crushing chest pain? Does it radiate? What brought it on? What were you doing? What makes it better? What makes it worse? Those are the type of things that, lead us, because someone comes in with chest discomfort, you already got in your mind, okay, they need nitro, they need morphine, but, there's other causes for chest pain. So we got to probe a little bit to, get our information. Which information regarding phosphodiesterase inhibitors and nitroglycerin administration is accurate?
D.
Yep, this is another fancy name for our ED pills. I've seen them both, so I thought it'd be good to put in here just so we see any of that specific meds that end in a fill, the sildenafil. I think there's a tildenafil, something like that, but those are all phosphodiesterase inhibitors. Which immediate action would the nurse take when a patient presents to the ED with chest pain?
C.
C.
Yep, it seems like the recommended standard is to get an EKG within 10 minutes of admission with chest pain. And then, I think we'd move to getting the labs and possibly doing imaging. Which of the following are absolute contraindications for thrombolytic therapy in a patient experiencing a STEMI?
B. C. D.
Yep. So these are our big guns, right? They're breaking up clots. So, recent head injury, that's the risk for intracranial hemorrhage if they've had it before, and active bleeding. Don't want to do it. Okay, true or false, left to right cardiac shunts or defects result in signs and symptoms of cyanosis?
False. Isn't it
False.
acyanotic?
Yep. So it's like I get it mixed up all the time. I kind of have to visualize and think about it. So when we have a right to left shunt, the heart's moving from the right side of the heart, bypassing the lungs to the left. So we're not picking up oxygen, but we have the reverse here. Our blood's already been oxygenated, but it's going from the left side back into the right to the lungs again. Which of the following signs and symptoms would be typically seen in a child with a right to left cardiac shunt? So diaphoresis and grunting during feedings. So let's just pause real quick. What kind of, like, are we dealing with acyanotic or cyanotic? Let's just get that in our brains.
Cyanotic.
Cyanotic.
Right, because we're going to the right to the left, so we're bypassing the lungs. So we're going to see those cyanotic symptoms. So actually, the diaphoresis and grunting during feedings, that's more with the left to right shunts. But they also don't feed as well. So it's kind of confusing, but even like the grunting during feedings, those are, which I don't know if we like really need to know this, but that's more, the grunting is like the key finding in the ventricular septal defects. But again, I don't know, if we need to know that for tomorrow or not. But the sweating and grunting during feedings is more seen with the acyanotic conditions. So moving on to polycythemia, what is polycythemia?
Excessive red blood cells.
Right. So do you think we could see that if we're having an issue with oxygenation?
Yes.
Right. Our body doesn't really recognize it's an issue with the heart. We just know we're not getting oxygen where it needs to go. So we're going to produce more red blood cells to try to carry more oxygen. And with that, what's our like big concern with polycythemia?
Thromboembolism.
Yep. PEs, strokes. I don't really know if it'll be on the test tomorrow or not. I mean, it was in that video that Jen had us watch. It's like the critical value of hemoglobin that has to be reported.
22.
Yep. And then managing, you know, one of these patients with the polycythemia. What is our
Priority is hydration.
yeah, thanks. And then clubbing of the fingers.
Yes.
Yeah, if it goes on long enough, it's chronic hypoxia, so we can see the clubbing of fingers. And then weight gain. No, we see that more the left to right shunts where we're getting the pulmonary congestion. We're not perfusing well to the kidneys, so we're not getting rid of fluid. Going along with that, the periorbital edema, is left to right, and then cyanosis. We're not carrying enough oxygen, so we're going to see cyanosis. So this one is B, C, and F. Okay, which education point should the nurse include regarding management of TET spells to the parents of a newborn with tetralogy of Fallot? I'm sorry to hit you with like a bunch of select alls, but I had to put these questions together myself, so it was kind of hard to try to break them up. So we have a newborn. So are we going to place the child on their feet into a squatting position?
No.
What are we going to do?
Knees to chest.
Knees to chest. That's right. And then give small and frequent feedings.
Yes.
Yeah, that'll help, reduce the incidences of those hypercyanotic events, which is what, the technical term for a TET spell is. So give them breaks, small feeding so they're able to oxygenate a little bit better, and then avoid offering a pacifier when the child cries.
No.
No, I mean, it could help soothe them. So if that, reduces that stress, we're going to want to do it. And then providing a calm and quiet environment when the child wakes up.
Yes.
Yeah, we don't want to stir the pot. And then swaddle or hold the child during procedures.
Yes.
Yeah, it's going along with the whole pacifier thing, help soothe the child. And then allow for an uninterrupted sleep.
Yes.
Yep. So A is no, do the knee to chest. And then B, C, D. Yeah, everything but A. No, sorry. B, D, E, and F. Which of the following are signs and symptoms of heart failure in a child with tetralogy of Fallot? So, I mean, this is pretty, I guess, sort of straightforward. Weight gain and periorbital edema. Yeah, we can see that. That's the fluid retention. Warm red extremities. Are we going to see that?
No.
No, they'll be cool and pale. And then, because we're lacking perfusion to the kidneys, we're going to see a decreased number of wet diapers and then decreased feeding. We'll see that. So this one will be A, B, D, and E.
A, B, and E.
Yeah, my bad. Which of the following treatments would be anticipated for a child with Kawasaki's disease?
B.
Yep, this is the one where they use the IV immunoglobulin. I don't know. I don't even know if this is really going to be covered or not. I'm not sure if we're really focusing on just the cardiac shunts and some of the other cardiac, there's rheumatic carditis. I'm not really sure. Did Jen say specifically like what's going to be really inclusive?
She really didn't.
Yeah. I mean, we didn't even do a patho class on this, so I don't know. I feel like a lot of it's going to be the cyanotic disorders because the tetralogy of Fallot and the transposition of the great arteries, those are the most lethal ones. And then really the other ones, the left to right shunts, they, lead to symptoms of heart failure. It's really just the, what you see with it. You see weight gain from fluid retention, but you see poor weight gain developmentally. And then, they don't tolerate feedings very well. Yeah, you get the edema, the dyspnea. I mean, I don't know how in depth she's going to go or not. But the nurse is feeding an infant with heart failure. Which intervention should the nurse implement?
A.
Yeah, that's holding them at that angle as opposed to horizontally. It decreases venous return to the heart, which decreases the workload on the heart. So, what is going on? Burp the infant only after completing the feeding. You can burp them as they go, give them breaks. Spacing at 6 hours apart is too much. It should be more frequent, and they only need feedings through a tube if they have like extreme dyspnea, during the feeding and they're like inhaling, aspirating. Which of the following cardiac defects is indomethacin used to treat? Indomethacin is an NSAID. So this one's for the patent ductus arteriosus. It helps it close. I guess it helps cause constriction, helps it close. Tetralogy of Fallot, that's corrected with surgery. The atrial septal defects and the ventricular septal defects, they can either close on their own or they can do a surgical procedure to close them. The patient has decreased pedal pulses and no claudication. Which stage of peripheral arterial disease would the nurse suspect?
A.
Yep, that's going to be our stage 1. Stage 2 is where we start seeing the intermittent claudication. The symptoms are reproducible. They get the, pain in like their calf muscles. Stage 3 is pain at rest. It's like almost like a toothache pain. Um, you know, pretty much, very frequently or all the time. And then stage 4 is like the gangrene and necrosis where, the tissues are really not getting anything. Stage 1 is asymptomatic. They don't experience anything. A patient reports calf muscle pain after walking 1 to 2 blocks. The nurse finds a pale ulcer with even edges and little granulation tissue at the end of the toes. Atrophy of the skin, cold foot, and absence of pulses. Which interpretation would the nurse make?
See?
Yeah, it's arterial. The pale ulcer, it's kind of a hint that there's not much perfusion getting there, little granulation tissue. It being at the end of the toes, the foot's cold, the skin's thin, and we don't have pulses, so those are all, um, you know, big hints to arterial. Which action by the patient would likely decrease symptoms of peripheral arterial disease? So, will we want them to limit fluid intake?
No.
Nah. And then wearing socks at all times?
Yes.
Yeah. And I kind of didn't like that answer choice because a lot of questions, like, a lot of times it's wrong if it says all, but I guess, do they got to wear socks in the shower? I don't know. Avoiding exposure to the cold. Yeah, because, the cold causes vasoconstriction, so that'll decrease blood flow. Applying direct heat. No, they start, they can lose sensation and they're susceptible to burns in that case. And then avoiding caffeine consumption. Caffeine vasoconstricts, will decrease blood flow. So that one's a yes. So this one is B, C, and E. Nope. Patient has increased sensitivity to cold, ulceration on the digits, the fingers, and claudication on the feet that worsen at night. Which condition would the nurse suspect? So this one's Berger's disease, which is does anyone know the primary risk factor for this?
Smoking.
Yep. So that, causes damage to like the smaller and more, I don't know, intermediate
Oh, this is
size
the
blood
Marble
vessels.
Man one.
Yeah. Yep. And this one, remove the causative agent, smoking, avoid caffeine, keep the, extremities warm. Very similar to arterial disease. And even with like both arterial and venous disease, there's a lot of parallels to like diabetic foot care, protecting the feet, keeping them moisturized, protecting them from injury. Which information would the nurse provide to a patient who has venous insufficiency? So, I mean, with venous insufficiency, we're having trouble getting blood back. So, do we think compression would help?
Yes.
Yeah. And then pushing the stockings down for comfort,
No.
right? If anything, that can cause more constriction and cut off blood flow. So, they need to wear them correctly. And then, should they wear the stockings even while they're sleeping?
No.
No, they just wear them during waking hours. Then elevating their legs above the level of their heart.
Yes.
Yeah, that'll help promote return, and you can cross your legs, but only for short periods. That's a no. They should never cross their legs. So this one is A and D. Patients who are diagnosed with acute arterial insufficiency often present with which P of ischemia? Okay, so we got A&E. We got some of them.
It's gonna be A, B. mm, E.
Chantel's the closest. It's everything but C. It's pulselessness. So pain, we got the ischemia. So, um, you know, pain can occur from the tissues not getting enough oxygen, pallor, you're not getting the blood flow, pulselessness, with a occlusion, paralysis, going along with lack of perfusion and paresthesia, and then poikilothermy. Does anyone remember what that is? Yeah, it's coldness. So if someone develops like an acute occlusion, what type of like therapy is like going to be implemented immediately? So we're going to put them on anticoagulant therapy. So we can try to reduce, any further clotting or spread of a clot. They might put in that I can't remember what it's called, like that umbrella thing that goes in the inferior vena cava to try to catch the clot if it breaks off. I'm hoping we're still kind of familiar with, signs of DVT, pain, swelling, redness in the legs, don't massage the site, have them elevate. People with peripheral arterial disease, they might be on anticoagulant therapy or antiplatelet therapy as well. So that's it, guys. That's all I got. I hope that was helpful, and I really covered mostly everything except for the valvular problems like mitral stenosis up to aortic stenosis. Real quick before you all jump out, because there's so many of you, I'm just going to take screenshots of the participants so I can record it. Bear with me for a second. All right, you guys are good to go. Thanks for coming. Hope you all are ready for tomorrow, and see you then.
Thanks, Joe.
Thanks, Joe. We appreciate you.
No problem. All right, have a good one, everyone.
Remember, it's 10 a.m. tomorrow, not 11.
Yeah, I'm kind of happy for that because I'm supposed to meet with someone at 12:30, so